Okay, Assalamualaikum and good evening, everyone. Thank you for finding your time and joining our CME organized by CME MedTweetMY Professional. I'm Adila, your moderator for today. Before we begin, I would like to remind if you have any question, you can write in a Q&A box below and we will address your question towards the end of our session. And from this CME, you will get 1 CPD point and we provide the link for the e-certificate and also CPD at the end of our session. And today we are privileged to host Dr. Rashdan Zaki bin Mohamed, a distinguished consultant pediatrician and pediatric endocrinologist from Hospital Pakar Damansara 2, who will be delivering a presentation on the topic of growth and short stature. Dr. Rashdan Zaki was born in Batu Pahat, Johor. He completed his MBBS in University of Malaya, then his master in pediatrics. Dr. Rashdan began his clinical fellowship pediatric endocrinology at University Malaya Medical Center, UMMC, in 2015, and then afterward in National University Hospital Singapore in 2019. Dr. Rashdan has published numerous research papers, particularly in the area of diagnosis of growth hormone deficiency in childhood, as well as child obesity. Dr. Rashdan plays an active role in social media as well, advocating and promoting child health and safety, especially in the field of pediatric endocrinology. He is currently an author of www.drbudak.com, an online avenue for parents to get information about their child healthcare. Dr. Rashdan's articles have been published in national dailies such as Harian Metro, and he also appeared as panel in various talk shows such as obesity di kalangan kanak-kanak via the Astro Awani. So Dr. Rashdan's area of interest include metabolic syndrome in obese children and non-alcoholic fatty liver disease in children as well. So without further ado, I would like to invite Dr. Rashdan to share his knowledge on this topic. So please welcome Dr. Rashdan.
Okay, Bismillahirrahmanirrahim. Assalamualaikum and a very good evening to all. And then first and foremost, I would like to thank Adila for kind introduction. I would like to thank Dr. Iskandar Mirza for kindly inviting me to join this MedTweet webinar. And of course, I would like to thank webinar as well. And I would like to thank all the participants tonight. So before I start, I would like to firstly apologize for some technical issues because sometimes my internet line here at Bukit Lanjan is very unstable. Hopefully we get through tonight without any technical glitch. So for that, I will share my screen now. Okay. Okay, so my task for today is to deliver a talk on short stature as well as growth. So the title of my presentation is Understanding Child Growth, Approach of a Child with Short Stature. So I hope that I can deliver this talk within 45 minutes and we have a good 15 minutes of Q&A session. Okay, so it all started back in 2015, whereby we found that the growth stunting in Malaysia, the prevalence is as high as 17.7%. And to our surprise is following the National Health Morbidity Survey in 2019, the prevalence is increasing in nature and it was escalated to 21.8% in 2019. And based on my latest information, we found that the prevalence, the growth stunting prevalence is now jumped to almost 30% in 2023. So recently, I've been invited by TV Al Hijrah to talk on again the same problem, short stature, as well as I've been invited to join this Hello Doctor as well to talk on this growth stunting. So I believe that Ministry of Health together with our government start to realize the importance of this issue, in which we found that the growth stunting in Malaysia has been increasing in pattern from 17.7 to 21.8 to now almost 30%. So if we focus to each states in Malaysia, we found that those children in East Coast, namely Kelantan, Terengganu, as well as Pahang, they have the highest growth stunting prevalence in Malaysia. So basically, the growth stunting in Kelantan is as high as 34%, and in Pahang 25.7%, and in Terengganu 26.1%. So to our surprise as well, those children in Putrajaya, okay, the growth stunting prevalence is also very high, about 24.3%. So we found that most of the time, this is maybe related to a lot of factors as well that we're going to discuss after this. And in Malaysia, the tallest children in Malaysia is those from Wilayah Persekutuan Kuala Lumpur, with the growth stunting prevalence as low as 10.5%. But having said that, it is still relatively high compared to upper middle income countries, whereby the cutoff is only around 6.9%. So we can see here that this is a really significant issue, whereby we found that not only that, generally speaking, that our prevalence of growth stunting is increasing in trend, but those with lower growth stunting prevalence is still relatively very high compared to other upper middle income countries. Okay, so for today, we're going to discuss the importance of early recognition of growth failure, approach of a child with short stature, and the benefits of early referral, early intervention, and early therapy. So, what factors contribute to the growth of a child? So this is the determinants of the childhood growth, basically genetics. So when a pediatric endocrinologist talk about genetics, it means familial genetic potential, genetic syndrome, all right, genetic non-syndromic as well. Okay, and then we know that for the first 2 to 4 years old, nutrition plays a very important role, and the children needs an optimum nutrition, adequate sleep, sleep at least 8 to 9 hours per day, exercising to stimulate all the hormones, and then they need to be free from any chronic illnesses, and they need to have a functioning endocrine gland, together with stable and then stable psycho-emotional factor, love, happiness, and emotional support. So this is all the factors of the growth in a child. So this is a very important slide to show the phases of growth in a child. So we have 4 phases of growth, namely fetal, infantile, childhood, and pubertal growth. During the fetal life, which is contribute about 30% of adult height, uterine environment is very important, in which 2 important hormones are the insulin-like growth factor 2 as well as insulin. And then when the child is born, during the infancy, nutrition, growth, health, and happiness, as well as thyroid hormone is very important. So during the infancy, the child can grow up to 25 centimeters during the first year of life, and subsequently 7 to 9 centimeters per year for the first 2 to 4 years old. Subsequently, during the childhood growth, which is contribute about 40% of adult height, growth hormone, thyroid hormone, genetic, good health and happiness plays a very significant role, and the child can grow up to 5 to 7 centimeters per year. And during puberty, for the pubertal growth spurt, by the effect of our sex steroid hormone, the teenagers can grow 8 to 10 centimeters per year for the next 1 to 2 years. So we can see here at least 70% of adult height contribute during the childhood growth up to the puberty. Okay, so early recognition of a child with growth failure, importance because growth as an indicator of health. Growth is a fundamental characteristic of early childhood. Children usually grow in a predictable manner, and abnormal growth might indicate the presence of underlying disease or health condition in otherwise apparently normal child. Frequent and accurate assessment of growth is of primary importance for physicians and nurses caring for children. So poor growth may be the first signs and symptoms of underlying health problem. So from this study, we found that a cross-sectional analysis of 104 consecutive patients who presented to endocrinology clinic in a developing country for evaluation of short stature, and we found that 23% of cases has a chronic medical illness causing the poor growth that includes renal diseases, hematological diseases, diabetes mellitus, as well as celiac disease. So short stature should be thoroughly evaluated to establish the exact cause. Treatable conditions should be identified at the earliest so that the proper therapy can be administered and optimal height could be attained. So consequences of delayed diagnosis of Turner syndrome, late diagnosis, late referral that leads to delay in intervention cause our Turner girls to have short adult height, reduced bone density, reduced sexual function, reduced academic achievement, and poor socialization. That's why it is very important to pick up the short girls to diagnose with Turner syndrome so that we can reverse all these negative outcome. And the condition affecting growth may also be affecting other systems, for example, cardiovascular system, nervous system, renal, immune, respiratory, metabolism, and puberty, GI tract, and definitely it will have impact on quality of life as well. So emotional well-being, self-rated health, educational achievement, social functioning, life satisfaction, and chronic psychosocial stress all has been found related to the effect of the growth stunting. So early recognition of growth failure very important because we want a good outcome in terms of good health, in terms of good nutrition, free from chronic illnesses, functioning endocrine, and any associated system. So how we recognize and approach a child with growth failure? So basically, when you see a short boy or girl, you need to answer three main questions. Number one, is the height normal for the population, or indirectly you can ask whether the child is short for population. The second question is whether the child is relatively short for the parental height or genetic potential. And number three, what is the growth velocity? What is the rate of growth of the child? Okay, so please bear in mind that growth velocity for a different growth basis as we discussed earlier. Okay, so by definition, short stature is defined when the height is less than -2 standard deviation, indirectly minus the less than third percentile from the growth chart. So, and then we know that this is a very typical of the bell-shaped curve. Mean or average is on the 50th centile, and the short stature is defined when you have shorter than -2 standard deviation. Okay. And from our monitoring of a child during the immunization, the growth chart and the record kesihatan, previously we used NCHS chart, but after 2006, we changed to WHO chart. So we need to monitor the growth chart properly so we can detect early growth stunting deviation from the central chart. So in CPG 2010, most of Malaysian pediatric endocrinologists will use NCHS chart, growth chart in the clinic. So by definition, third percentile is used to represent -2 standard deviation. 10 centimeter below the mid-parental height represent -1.5 standard deviation below the mid-parental height, indirectly to say that this is short for the mid-parental height, short for the genetic potential, and 1 centile band on the growth chart represent 2/3 of a standard deviation. This is based on our local Malaysian growth hormone CPG back in 2010. So just to stimulate some discussion. So which growth chart to use? Either WHO chart, typically for the first 2 to 5 years during the usual routine medical checkup during the immunization. As I mentioned earlier, after 2006, the buku rekod kesihatan bayi dan kanak-kanak, we use WHO chart. But in majority of pediatric clinic or pediatric endocrine clinic, we are using the NCHS CDC chart. So what is the difference between these two charts? So WHO basically international selected communities, compared to NCHS basically only the United States population. And then WHO reflecting longitudinal growth and healthy growth under optimal environmental and health condition, and it's reflecting the breastfeeding population compared to NCHS chart, whereby this is basically the cross-sectional study reflecting children in United States over 30 years from 1963 to 1994, and basically a predominantly formula fed children. Okay, so which growth chart to use? Do we have our own standardized growth chart for Malaysian children? So when I look further, we found that back in 2015, we have our local Malaysian growth chart. So this is based on National Health Mobility Survey in 2006, whereby almost 11,000 boys and girls from birth to 18 years old, we monitor the height, and actually we have a specific local my growth chart, but somehow we are not using it. We are more into WHO as well as NCHS chart. So if we found based on from our study, Malaysian growth chart, basically during the first year of life, our Malaysian boys and girls are slightly longer compared to WHO, but subsequently we are 3 to 4 centimeters shorter, 3 to 5 centimeters shorter compared to WHO chart. So I was thinking, maybe if you use by both chart, nation growth chart, our starting prevalence will be lesser, something to ponder. Okay, but what more important to me is I can see that as a Malaysian adult, we are getting shorter and shorter compared to our neighboring Asian countries lah. So basically, average Malaysian male is around 164 to 167 centimeter, and female around 154 to 157 centimeter. But if you compare to Singaporean, the males the Singaporean man is about 170 centimeter, and Singaporean ladies is about 160 centimeter. Japan as well as South Korea, they are much taller, 171, 175 centimeter, and the ladies are around almost 159 to 162. So the Korean, the K-pop population, they are much taller compared to us. And to start with, many years ago, in terms of the socio-demographic data, Malaysian and South Korean actually not much different. But we can see with time, they are much taller. This is reflecting of the nutritional aspect that has been emphasized in South Korean as well as Japan. So, majority of us, pediatric endocrinologists, we have our own apps that auto-generating standard deviation based on the measurement. However, not widely available, and in some clinics, we still need to use the growth chart. So when we should concern, severe short stature by definition is height less than -3 standard deviation. Remember, any children less than -2 standard deviation is considered short stature. -3 standard deviation is considered severe short stature. Height less than -1.5 standard deviation for mid-parental height. So remember that this is equivalent to 10 centimeter below the mid-parental height. Okay. When the height is less than 2 standard deviation and with poor height velocity, or what we can see here that the growth of the child is basically the start to crossing centile, so you need to be concerned as well. And any signs of intracranial lesion, multiple pituitary hormone deficiency, clinical features suggestive of growth hormone deficiency in neonates, we need to be concerned as well. Okay, so as I mentioned earlier, majority of us in clinic, we don't have any application that we can generate the standard deviation, although some online calculator can give you that standard deviation, but majority of the time we still need to use our, our growth chart. So what we can do is, number one, we need to calculate the mid-parental height. The formula is down here, all right? And then subsequently, the target height is 10 plus minus 10 centimeter of the mid-parental height. So this is what we call as target height or genetic potential, whereby the children can grow along this so-called genetic potential. So for example, here we can see that both parents, the mid-parental height is somewhere in 75th centile. So they can be as tall as 190, as short as 170 during the adulthood. Okay. I can see here, I can plot here that this is the current height of the child. You can say that this child definitely short for the population, as it is less than less than third centile, definitely less than -2 standard deviation, and even the shortest genetic potential here, the plus minus 10 centimeter, is about 10 centile, and the child is definitely short for the genetic potential as well. And we need to, have severe measurement, and we can see here that initially the child is growing well, but subsequently start plateauing and causing centile. So we can calculate the height velocity. So basically, the height velocity is depending on the phases of growth. As I mentioned earlier, during the first 2 to 4 years, the child can go 7 to 9 centimeter per year. Subsequently, about 5 to 7 centimeter per year. During the puberty, it's about 8 to 10 centimeter per year. But if you can't remember any magic number, just remember that the child need to go at least 5 centimeter per year. So anything less than 5 centimeter per year, we need to be concerned. Okay. So recognizing growth failure in a child, so we have to answer 3 main questions: short for population, short for the genetic potential, as well as poor height velocity. So we need to see any factors that may contribute to this child growth failure. So short for population, short for genetic potential, as well as poor height velocity. So evaluation of a child with growth failure. So we need to have a detailed history taking. We need to have growth measurement. Repeated measurement over time are more informative to show the pattern of growth and growth velocity. We need to have a thorough clinical examination, including pubertal staging, and subsequently we need to do some investigation. Okay, so in terms of the history, presenting complaint, the growth, puberty, associated symptom, for example, weight loss or weight gain, visual disturbances, headache, polyuria, we need to have a detailed history taking. So basically, the parents will complain that the child is the shortest or smallest in the class, or the cousins or younger sibling, the younger cousin or younger sibling start to catching up on the child, or even taller compared to the child. So this is another concerning symptoms. And then the other thing is, most of the parents will tell you that they hardly outgrow their shoe size, hardly outgrow their clothing size. So basically, if you have a small children, we know that we have to change, the child will outgrow their size every 6 months to 1 year. So when you get the history, ask whether how frequent you have to change the shoe size or the pant size, and you will be surprised that for the last couple of years, the child basically not growing that much. Okay, we need to know the duration of the problem and the progress, and then we need to have a detailed past history that includes hypothalamic pituitary lesion, CNS trauma, radiotherapy, infection, tumor, surgery. We need to have a systemic illness review, dietary history, very important, because we know that the first 2 to 4 years, nutrition plays a very important role. History taking includes medication. Prolonged steroid therapy may actually cause short stature in a child. We need to have a good antenatal and neonatal history that include gestation, birth weight, any history that might suggest hypoglycemia, because we know that anything hypopituitarism may present with recurrent or intractable hypoglycemia. Neurodevelopmental history that includes speech, hearing, learning, vision, behavior, family history, consanguinity, parents' height, growth pubertal disorder, and we need to have a detailed social history, including school, for example, bullies, etc. Okay, in examination, we need to have some measurement that include weight, height, head circumference, height velocity, and the mid-parental height. We want to calculate the upper and lower segment ratio, because we want to know whether this is proportionate or disproportionate short stature. We want to measure the arm span. We want to look for any dysmorphology, for example, Noonan syndrome, Turner syndrome, Russell-Silver syndrome, and we need to do some maneuver to look for all this dysmorphology. Midline defect that might suggest hypopituitarism, for example, cleft lip, cleft palate, as well as micropenis. Growth hormone deficiency, usually the presenting sign and symptoms include mid-facial hypoplasia, cherubic facies, abdominal adiposity. We want to look for any skeletal abnormalities that might suggest skeletal dysplasia, and then we want to complete our evaluation by checking all the systemic examination, nutritional status, as well as pubertal staging. So this is the correct technique how to measure height, the standing height. So the head held in the frontal plane, feet together, heel against the backboard, and then we want to measure it properly. All right. And then for the first 2 years, sometimes very difficult to ask the child to stand up. So we need to have the measurement of the supine length, hold head against the headboard in the frontal plane, assisted to strengthen knees, and hold feet flat against the footboard. Okay, so pubertal staging. So just out of discussion, we know that the girls started their puberty much earlier compared to the boys, and the growth spurt are actually earlier compared to the boys. So the growth spurt happening sometimes around 10 to 12 years old, breast tender too. Compared to the boys, the growth spurt comes later around 13 to 14 years old, whereby the testicular volume is around 10 to 12 mils. And then this is significant because, as we can remember, that the growth spurt in the puberty happens in the female much earlier compared to the boys. Okay, and we know that nowadays the girls are getting their puberty are getting earlier and earlier. So we have a lot of factors contributing for that. This is another open discussion. All right, but I always tell people that if you found that the girls started puberty at breast tender 2, and yet the height is less than 130 centimeter, 130 centimeter, you need to refer to us, because we know that for the pubertal growth spurt, about 8 to 10 centimeters. So maximum they can gain for that 2 years of puberty is around 20 centimeters. So if the girl started their puberty less than 130, the estimated final height will be less than 150 centimeters. And 150 centimeters is relatively kind of short for a Malaysian woman. So how we approach a child with short stature? We want to ask whether this is a proportionate or disproportionate short stature. Disproportionate short stature, whether this is a short limb that might suggest skeletal dysplasia, or short spine because of the irradiation scoliosis. And proportionate short stature can be a normal variant, or this is something pathological. Normal variant include familial short stature and constitutional delay in growth and puberty. Pathological include the mnemonic is nice, NICE. So nutritional factor, intrinsic factor that include genetic syndrome, as well as SGA without catch-up growth. C, any chronic illnesses. and E, endocrine and emotional factors. So genetic syndrome include Turner syndrome, Noonan, Russell fever, and those short and obese, please remember Prader-Willi and pseudo hypoparathyroidism type 1A, pseudo or we call it Albright hereditary osteodystrophy. And endocrine problem include growth hormone deficiency, hypothyroidism, pubertal disorder, early puberty or precocious puberty. Initially, they are very tall, but subsequently, as an adult, they are very short because of earlier closure of the growth plate, and delayed puberty also can lead to short stature and Annie-Cushing syndrome. Okay, causes of growth hormone deficiency, congenital developmental abnormalities of the hypothalamus pituitary present in infancy or early childhood, septo-optic dysplasia, optic nerve hypoplasia, midline brain abnormalities, defect in certain genes acquired include tumors, irradiation, trauma, infiltration, as well as infection. So investigation, usually I will do some basic baseline investigation that includes full blood count, renal profile, liver function test, ESR, CRP, okay, blood gas, bone profile, and if you suspect celiac disease, maybe celiac antibodies. And sometimes we need to proceed with some baseline investigation of thyroid function and IGF-1. If you suspect hypopituitarism, then we want to proceed with cortisol and prolactin, as well as LH, FSH, testosterone, if you feel that the child is in puberty. And we always say that for a short girls, it is recommended that we do karyotyping for all short girls, and we want to request for 60 cell just to be sure that we won't miss Mosaic-Turner syndrome. And majority of the time, we need to do the growth hormone dynamic or stimulation test, namely insulin tolerant test, as well as glucagon stimulation test. But this test must be referred to pediatric endocrinologist. And I always do bone age as my earlier or initial evaluation, because it can guide the etiology and prediction of the final height. Not only guiding, but also predicting the final height. And we know that the final height is achieved when bone is around 15 years in girls and 16.5 years in boys. That's why we want to catch all this before they presented at teenagers with advanced bone age, and there is too late for intervention. So any discrepancy more than 2 years, for example, too advanced or too delayed more than 2 years of the chronological age, we need to be concerned, okay? And then before initiating growth hormone therapy, I always do MRI pituitary just to make sure that I don't want to miss any tumors, because you know the outcome when you give growth hormone therapy, the child has tumor, it will cause the tumor to be larger and larger. Okay, growth hormone testing, either insulin tolerant test, glucagon stimulation test. Some center use arginine clonidine. I personally use ITT, GST, as well as exercise stimulation test. Arguably, multiple studies have demonstrated that provocative growth hormone tests are fully reproducible, had variability of growth hormone assay, different cutoff level, other factors including BMI, pubertal status, priming, standardization protocol, diagnosis sensitivity, and specificity that might affect the report or the result of the test. Okay, so one, we confirm that the patient is growth hormone deficiency. How we confirm that? Clinical and osological criteria. Short stature, as I mentioned earlier, less than third centile, or the standard deviation -2, and poor height velocity. And subsequently, when we do the growth hormone stimulation test, the peak growth hormone level is less than 10 microgram per liter. So this is relatively a higher cutoff. In Singapore, when I was trained there at National University Hospital Singapore, the cutoff is only 6.7. Compared to Malaysia, we put a higher cutoff of 10 mic per liter. And radiological criteria includes delay in bone age. All right. So after the confirmation of the growth hormone deficiency, subsequent investigation should include MRI of hypothalamic region and genetic study if feasible. Okay. So growth hormone therapy, we have identified the child has growth failure. namely short for population, short for genetic potential, as well as poor height velocity. And subsequently, when we do the test, the specific growth hormone testing, either ITT, insulin tolerant test, or glucagon stimulation test, we found that the child has growth hormone deficiency. As the cutoff is less than 10 microgram per liter, this child is actually candidate to give growth hormone therapy. So in Malaysia setting, based on our CPG 2010, only 3 indications for growth hormone therapy subsidized in Malaysia. Number 1 is growth hormone deficiency, confirmed by the insulin tolerant test as well as glucagon stimulation test. Number 2, Turner syndrome. That's why all short girls, we want to catch we want to do the karyotyping because we want to catch Turner syndrome or Mosaic Turner syndrome, so that we can offer this growth hormone therapy. And number 3, SGA babies, small gestational age babies without catch-up growth. This is another group of children that actually we can give subsidized growth hormone therapy. So if you have any SGA less than 2.5 kilo birth weight, and we found that there is no catch-up growth at around 2 to 4 years old, please refer to us, because we want to catch all this group of people so that we can offer the growth hormone therapy. Okay, so once we start the growth hormone therapy, the predators and the golden period are, the earlier the therapy we start, the better the outcome. The longer the therapy, the better the outcome. And the first year response is always the best response during the therapy period. So early diagnosis and early treatment result in greater height gain. As we can see here that changes in the height estates over 4 years of growth hormone therapy, both in growth hormone deficiency as SGA, we found that we can see here that the earlier we start, the better the outcome. And you can see here that if you start at around 2 to 5 years old, the outcome of the height changes in the height gain is much better if compared to you start later age. Okay. Earlier therapy, near adult height, this is based on study of 172 pediatric patients with isolated growth hormone deficiency. Near adult height SDS was significantly higher in patients starting growth hormone therapy early. So girls less than 8, boys less than 9, compared to those starting treatment at older age. So early initiation of growth hormone treatment in children with isolated growth hormone deficiency improve their chances of achieving their genetic height potential, as shown by this graph. Okay. The longer the duration, the better the outcome. Of course, we want at least 4 years of a good growth hormone therapy. 1 year, 2 years also give benefit to a child, but the longer, at least 4 years of therapy is a better outcome. That's why I always say that we want a referral before the age of 12 years old, because you know by 15, 16, the bone close, so at least the child has a solid 4 years of therapy to see the really, really good outcome as stated in this study. Okay, and we know that puberty has its negative effect on height. A normal but early puberty exerts a negative effect on adult height. And then you see height and height velocity are increased and bone age is advanced. The advanced bone age, about 3 years over the chronological age, result in decreased predicted adult height. That's why we don't want, and we found that nowadays our girls, they puberty much earlier. That's why I say that if you found that the girls starting their puberty at breast standard 2 and yet the height is less than 130 centimeter, 130 centimeter, please refer to us, because we know that the outcome, the final height, if we don't treat, if we don't do something, will be around 150 centimeter, which is a little bit short for a female. Okay. Adult height is influenced by both height and the age of onset of pubertal growth spurt in a normal maturing children. And if the onset of puberty occurs early, for example, 8 rather than 10, the child may lose about 1.2 standard deviation in adult height. So puberty, although it's good, it is normal, it can cause negative effect on the height. And the first years of therapy is always the best, as indicated by this study of 99 children. The height velocity was highest during the first year of treatment, declining on the subsequent years of treatment. So the first year therapy, you can go up to 10 to 13 centimeter per year. And subsequently, even on the growth hormone therapy, the so-called height velocity is around 7 to 8 centimeter. But we know that if you don't treat, the height velocity for this group, for those growth hormone deficient, they can hardly have less than 5 centimeter per year. Okay, the benefits of early recognition, diagnosis, and treatment. Poor growth may be the first signs of an underlying health problem. Early detection of abnormal growth and identification of underlying causes is critical to appropriate treatment. Early and appropriate treatment of pathological conditions associated with short stature will usually prevent growth deterioration and associated complication of the disease. So early diagnosis is important in the management of poor growth and in the promotion of health of the children. And we want to detect early so that we can institute or administer treatment early, because we know that the psychosocial impact of short stature that include impact health-related quality of life, more likely to be bullied, greater risk of internalizing behavior problem, lower self-esteem, and a greater degree of social isolation compared to their taller peers. So assessing the psychosocial impact of short stature is compared and very important to understand that it can influence psychosocial functioning and quality of life. So consequences of the late recognition and treatment, delayed diagnosis of poor growth may lead to short stature in adult life and associated poor health. As evidenced by growth failure before the age of 2 years is an important cause of short adult stature. Late diagnosis may lead to suboptimal management of comorbidities such as renal diseases, hematological disease, renal disease, diabetes, and celiac disease. Growth failure in early childhood is linked to impairments in both physical and cognitive development, lower academic attainment, lower income, and poor hand grip strength. Okay, so when to refer to as pediatric endocrine, pathological short stature or poor growth velocity. As I mentioned, Turner syndrome, SGA without catch-up growth, and growth hormone deficient are three main groups that indicated for subsidized growth hormone based on Malaysian CPG 2010. Neonates or infant or children with features of growth hormone deficiency, including midline defect, recurrent intractable hypoglycemia, poor growth micropenis, okay, and suspecting any endocrinologist that include Cushing syndrome, delayed or precocious puberty, growth hormone deficiency. So, who should be investigated for growth hormone deficiency? As I mentioned earlier, those with persistent intractable hypoglycemia, convulsion, or any midline defect, including micropenis, craniofacial defects such as cleft palate, cleft lip, okay, traumatic delivery, postnatal or neonatal jaundice. Sometimes it may signify hypopit that leads to growth hormone deficiency. So, who should be investigated for growth hormone deficiency? In older children, those children that undergoes surgery to the hypothalamic pituitary region, cranial irradiation, history of tumor including craniopharyngioma, traumatic brain injury, CNS infection, signs and symptoms of multiple pituitary hormone deficiency, any indication of intracranial lesion, consanguinity, failure to show normal growth spurt by breast stage 3 in girls and genital stage 3 in boys. So basically all this, we should investigate for growth hormone deficiency. So the take-home message, careful history, physical examination, growth pattern, puberty and assessment. Short stature more likely to be pathological if poor growth velocity, short and overweight, and inappropriately short compared to parents. We have to rule out chronic and illnesses, optimize nutrition, and please remember that all short girls, we need karyotyping to diagnose Turner and Mosey-Turner syndrome. So for that, thank you very much.
Okay, thank you, Dr. Rashdan, for a detailed explanation on growth and also short stature. So as we know, growth is a fundamental characteristic of childhood, and also poor growth may be the first signs of an underlying health problem. So we have a lot of Q&A. So I'll pass the floor to Dr. Faiz for the Q&A session with Dr. Rashdan. Okay, please welcome Dr. Faiz.
Okay. Thank you, Dr. Adila. And again, thank you very much, Dr. Rashdan, for a very amazing and insightful lecture. We got quite a number of questions tonight, Dr. Rashdan. So I think without further ado, we jump to the first one. How to measure upper segment to lower segment ratio?
Okay, so this is a very good question. So upper segment, usually there is a special stadiometer. We call it sitting stadiometer. The usual stadiometer or measurement of height is the standing stadiometer. So if you have in your clinic a sitting stadiometer, you can measure the upper segment. Unfortunately, many of us, we don't have the sitting stadiometer. So what we can do, you can measure the lower segment. How to measure the lower segment? Ask the child to stand up and you measure from the symphysis pubis down to the floor. So this is the measurement of your lower segment. And how you get the upper segment? The height minus the lower segment, you can have the upper segment, and you do the ratio lah. Upper segment divided by the lower segment. Majority of the time at 10 years old, the ratio should be 1. So if you found that the ratio is high, it means that the upper segment is taller or longer compared to the lower segment. Then you have to see that possibility of skeletal dysplasia because they have shorter limbs. As compared to if your upper segment to the lower segment ratio is less than 1 at 10 years old, and you suspect that the child has lower or shorter upper segment, then you have to suspect the spine. So upper segment reflection of the spinal kind of abnormalities.
All right, thank you very much, Dr. Rashdan. For those asking, actually, we will have our recorded session and we will release in our YouTube or our social media, just to inform everyone. All right. So the next question, okay. Doctor did mention about if a girl reach puberty at tenor stage 2 with the height less than 130 cm, need to refer slightly, child will only go up to 150 cm maximum. Is that because of a growth hormone deficiency?
Okay, I think I have to go slow on this aspect. I don't want to, I want to avoid confusion. So you just imagine, as I mentioned earlier, we have 4 phases of growth, namely fetal, infantile, children, and pubertal growth. So during the puberty, there will be a pubertal growth spurt. So during the pubertal growth spurt, the teenagers can grow up to 8 to 10 centimeter per year times 2 years. So basically, during the puberty, the whole process, there will be increment of around 20 centimeter of height. Okay. So, but there's a difference between boys and girls. The girls started their pubertal growth spurt much earlier compared to the boys. The girls started their pubertal growth spurt at 8 to 10 centimeter per year times 2 years at around the age of 8 to 10 centimeter during the breast tenor 2, the initial development of the breast tenor 2. Compared to the boys, they have their pubertal growth spurt much later at around 13 to 14 years old when their testicular volume of 10 mils. Okay, so coming back to the girls, as I mentioned earlier, that we found that nowadays our girls, they start puberty much early. So during the puberty, during the breast tenor 2, if the height is only 130 centimeter and below, if you plus that 8 to 10 centimeter per year times 2 years, or easily counting, you plus 20 centimeter during the pubertal growth spurt, 130 plus 20 centimeter, you have only 150 centimeter. as an adult final height. So 150 centimeter as an adult final height for female, for me, is relatively short. Okay, because we know that even for for now, our Malaysian ladies, the mean or the average height will be around 154 to 157 centimeter compared to Singaporean 160, Korean 160 plus. They are ladies. Okay, so that's why I've told you that if you have a case whereby you found that the girl started their puberty, breast tender 2, and yet the height is less than 130 centimeter, please refer to us because we want to intervene. We want to slow down or stop the pubertal process. We call it pubertal suppression because we want more time for them to achieve greater height, more than 150 centimeter. So it is not related to growth hormone deficiency per se, but it is related to puberty. And in my slide, I've mentioned that puberty has a negative effect because estrogen causing the bone to close. And bone maturity, the bone close is around 15 to 16 years old. But if the puberty comes early, the bone close earlier.
Okay, all right. Okay, understood, Dr. Rashdan. Jumping to the third question, is supplement will be useful to prescribe if nutrition is the cause? For example, vitamin in the case of a child below 14 years of age or before puberty.
Okay, very good. So as I mentioned earlier, especially during the infancy, especially during the childhood growth, nutrition plays a very important role. And when we talk about nutrition, it must be a complete, balanced, healthy diet that includes carbohydrate, protein, more importantly, protein, as well as minerals and vitamins. So yes, you can prescribe multivitamin. Yes, you can prescribe any vitamins, vitamin D, for example, or vitamin C as well. But you have to understand that vitamins alone is not adequate. It must be a complete, balanced, healthy diet. And we know for a child to grow, they need protein, milk, eggs, fish, chicken, meat. Okay, that's why we need a proper nutrition. Beside nutrition, number one is nutrition. Beside nutrition, they need to have adequate sleep. So our children, they need to sleep at least 8 to 9 centimeter per night because we know that the growth hormone are released at night during the sleep. Okay, that's why we need adequate sleep. So no gadget after 8:30. Ask them to go to bed by 9 to 9:30 so that they can fall asleep at 10 and wake up at 6 so that they have a solid 8 hours of sleeping for them to go. And number 3, exercise. A lot of jumping exercise. You know, we want the bone to be strong. We want a good bone density as well as we want them to have a stretch so that they can grow taller. So 3 important things: nutrition, complete, healthy, balanced, healthy diet, adequate sleep, adequate exercise.
Okay, all right. Thank you, Dr. Rashdan. Very detailed explanation. Okay, jumping to the next question. What advice should be given to patient with shorter height within peers, but still within normal range?
Okay, so this is maybe a case of normal variant. As I mentioned earlier, it could be familial short stature or constitutional delay in growth and puberty. So basically, majority of the time, we don't do anything. But for me, we need to also address this issue because if we have a generation of short, relatively short, then subsequent generation will be shorter and shorter and shorter, and Malaysian children generation in the future will be shorter compared to our neighboring countries, to other Asian countries, and we don't want this because we are now relatively shorter compared to Singaporean, Korean, as well as Japan, where when in terms of social demographic data at initial stage, they are more or less same with us. So I think, although I say that there's nothing much to offer in the principle of this could be a normal variant, we can always do something. We need to intervene through a natural, nutritional, sleep, as well as exercising. And sometimes I do offer certain therapies for them so that we can have a taller children and taller generation.
All right, understood. Okay, I think we have maybe another 2 questions down the line due to time limitation. Okay, Dr. Rashdan, for growth hormone therapy in Prader-Willi syndrome, before we start the therapy, we seldomly do growth hormone testing before the treatment. Very specific questions.
Okay. Very good question. I didn't touch on PWS, Prader-Willi syndrome. So you have to understand that in terms of indication, FDA approved international guideline, there's a lot of indication, including Prader-Willi syndrome. But for a Malaysian setting, because of the limited resources, we only give subsidy only for the 3 group of condition lah. Turner, growth hormone deficiency, as well as SGA babies without catch-up growth. I personally, when I was in Kelantan, I gave growth hormone therapy to Prader-Willi syndrome. So you have to understand that in terms of Prader-Willi syndrome, the strategy of the growth hormone therapy is different. It's not only for the height, it's more of the metabolic function for the body composition. And for the Prader-Willi syndrome, we have to give as early as possible, namely before the 1 years old, before the 2 years old, especially during the infancy, because once they become morbidly obese with comorbidities, they are contraindicated for the growth hormone therapy. And we know that typically in Prader-Willi syndrome, they started to gain weight, hyperphagia after 2 years old. So all our children, Prader-Willi children, if we want to start in the therapy, it must be before the onset of the obesity, usually during the infancy. So and then there is no indication to do the growth hormone testing, because the indication for the Prader-Willi is not for the growth hormone deficiency, but for the Prader-Willi itself. But in Malaysia, Prader-Willi itself is not under the so-called subsidized group of the therapy. But I know that team has been giving. I know that HKL, some of them receive growth hormone therapy. But as far as so-called guideline is concerned, Malaysian setting based on CPG 2010, Prader-Willi is not there. But FDA approved international guideline, I personally give growth hormone to Prader-Willi as well. Careful on the Prader-Willi, because one of the feared complication is the hypoventilation syndrome. That's why we need to have a good team, multidisciplinary team, including pediatric rescue.
Okay, all right. Okay, yeah, Dr. Rashdan, I think our last question here. What is the best time to start a growth hormone therapy in child with chronic illness, for example, thalassemia or those with a prolonged steroid use?
Okay, so basically, what we want to see is, as I mentioned, the earlier, the better, the longer, the better. The earlier the therapy, the longer therapy is always better. But for example, thalassemia itself. So before jumping and giving growth hormone therapy, you have to understand the pathophysiology of growth failure in thalassemia. That includes inadequate hemoglobin, prolonged anemia. So I will say that correct the HB, fulfill the hypertransfusion regimen strategies. The pre-transfusion HB must be always more than 9 to 10. The post must be always more than 13 to 15, and have a good iron chelation. So control the ferritin less to 1,000. And if you have fulfilled all that, and yet the child still poor growth or short stature, refer to pediatric endocrine for proper evaluation, including growth hormone testing. And sometimes we do give growth hormone therapy. But majority of time, I found that even for the thalassemia control itself is not adequate. So not fulfilling the hypertransfusion regime, iron chelation is, the ferritin is as high as 2,000, 3,000, 4,000, and yet you want to give growth hormone therapy for this group of children, For me, is this not recommended because we know that we need to tackle the basic of the thalassemia. Prolonged steroid use, sometimes we need to understand why they have the prolonged steroid use, and then can we control the disease with the lowest dose of steroid, for example, maybe 5 mg EOD before embarking and exploring the role of growth hormone therapy. Because we know that in terms of chronic illnesses, the fundamental thing is to control the disease first. The short stature is complication from the therapy or from the disease, the chronic illnesses.
Okay. Unfortunately, thank you, Dr. Rashdan. I think we need to put an end to our Q&A session because of time limitation. For those unanswered questions or any questions that are not being asked, I think can direct to our social media or even direct to Dr. Rashdan himself via his Facebook page. Hence, I pass the floor to Dr. Adila for the closing speech. Thank you very much again.
It's very great Q&A session. Thank you, Dr. Faiz. Thank you, Dr. Rashdan, for answering all the questions. Because of the time limitation, we are really sorry that we cannot answer all your questions. So on behalf of everyone, I would like to thank our speaker, Dr. Rashdan, on a very clear explanation on growth and on short stature. So now we have come to the end of our CME. Thank you for spending your evening with us. Hope you learn one or two from our session. And we have provided the link for the e-certificate as well as the CPD point in our chat box. You can click and fill up the form, and we will email you the e-certificate. And with that, I thank everyone and see you on next CME. Thank you.
Okay, thank you. Bye.
Thank you, Dr. Rashdan.
Thank you all. Okay, thank you.